from Jenna, really, there are so many issues relating to twins. A much higher risk of all pregnancy complications. And then in relation to embryo reduction that I was not planning to address in any specific way, it's a nightmare. We have women that are 45 years old that have been trying to get pregnant for more than 15 years. They eventually have an IVF, they get pregnant, they have twins, and suddenly they feel they cannot cope. And they come requesting an embryo reduction. And then they find themselves in a terrible scenario where they think they will solve a lot of their problems by having an embryo reduction, but in reality, that in itself creates a lot of other problems. We can perhaps discuss these issues later on. Let me move on now with the issues of screening and invasive testing. And basically, we have two types of invasive tests. We have amniocentesis, which is usually carried out at 16 weeks, and you have chorionic villus sampling, which is carried out at 12 weeks. Now, if we are doing an amniocentesis at 16 weeks, then I often prefer to use the same needle and go across the intertwin membrane and sample both of the babies at the same time. Because you have an assessment of risk. One baby has a higher chance, let's say, of having Down syndrome, and the other a lower chance. The parents want to have an invasive test, and you only test the baby that has the higher risk. But still, the baby with the lower risk still has a risk. And for me, if the chances of causing a miscarriage are no higher by doing this double needle type of procedure, it is preferable to test them both. Now, then we have the next issue. If we are going to do an invasive test in a twin pregnancy, we must always be thinking of what is the next step. And if one of the two babies is affected, one of the options for the parents is to have an embryo reduction. The later in pregnancy you do the embryo reduction, the higher is the chance that you will cause complications for the surviving baby. For example, if you do an embryo reduction at 12 weeks, the risk of causing a miscarriage of the surviving baby is about 5%, whereas if you do an embryo reduction at 20 weeks, the risk of causing miscarriage or severe early preterm birth in the other baby is about 20-25%. So in general, if you are going to have an invasive test, it is much, much preferable to do so at 12 weeks. The reason is very simple. The later you do the embryo reduction, the greater is the amount of dead fetal-placental products, and therefore the presence of the dead fetus and placenta causing triggering of a miscarriage of the whole pregnancy increases with the later stage of the embryo reduction. So, conclusion, if you're going to do an invasive test, I would prefer to do a chorionic villus sampling at 12 weeks rather than amniocentesis at 16 weeks, point number one. And point number two, if I am testing the pregnancy because one of the babies has a higher risk of a problem, I would prefer to test them both if the technique that you're using carries no greater risk of causing a miscarriage than if you only tested one. The risk of miscarriage from CVS is about 1%, and the same is for amniocentesis. But if the procedure is carried out by an expert, and that is why all of these things have to be carried out by experts that have a lot of experience, the risk can be as low as 1 in 1,000, not 1 in 100 that the NHS leaflets say, or even more, 1 in 1,000, provided you have an expertise in doing these procedures. Now, let me address another issue now, the outcome of twins. And this is a very nice table that if anybody wants to copy, it is a good opportunity to do so. And they have taken data from many thousands of singleton and twin pregnancies, dichorionic, monochorionic, monoamniotic. On the right, these are the survival type of curves. I start off with 100 babies alive at 12 weeks. And then as the pregnancy progresses, the number of alive babies decreases. And you can see that the number of alive babies in the singleton pregnancy are very high, whereas in a monochorionic, monoamniotic twin pregnancy, the survival rate is quite low. If we now go to the table, let's take each type of pregnancy complication in each type of a pregnancy. Copy this table, it's good for you. We have done an ultrasound scan at 12 weeks, and we see one baby that is alive. What is the chance that this baby will die by 24 weeks, so it is classified as a miscarriage? It's simple, really. One baby, 1%. In a dichorionic twin pregnancy, it's 2%. In a monochorionic twin pregnancy, it's 8%, and in a monoamniotic twin pregnancy, it's 22%. And it's as simple as that, and there's nothing that you can do to change this statistic. If we then go beyond 24 weeks, and now we call it not a miscarriage, we call it a stillbirth. What is the chance of a stillbirth in a singleton pregnancy? It's about 4 in 1,000. In a dichorionic twin pregnancy, it's a bit higher. It's twice as much. It's 1 per baby, 1%. In a monochorionic twin pregnancy, it's 2.5, and in a monoamniotic, it's 9%. The next set of important pregnancy complications is being born very prematurely. They call very premature before 32 weeks. More or less in England, if somebody is born after 32 weeks, they will survive and they will be all right. The killing fields of what I call in obstetrics is birth at between 24 and 32 weeks. That is where a lot of babies can die in the neonatal period, and a lot of babies that survive can be handicapped because of the prematurity. And obviously, the closer we are to 24 weeks, the higher is the chance, and the closer we are to 32 weeks, the lower is the chance. But if we take the overall chance of premature birth in a singleton pregnancy is 2%, in a dichorionic twin pregnancy 7%, monochorionic twins 14%, and monoamniotic twins massive, 27%. And then the next type of pregnancy complications are small babies, 5, 31, 38, 33%. So each type of pregnancy complication is much higher in twins than in singletons, and much more so in monochorionic and monoamniotic twins than in dichorionic twins. Let's now go to antenatal management. The summary of that, well, these are part of putting together various recommendations. Everybody should have a scan at 12 weeks, where we're measuring the crown rump length and the nuchal, irrespective of whether you want to have screening for chromosomal abnormalities, as I mentioned. The nuchal is important for other problems, including early diagnosis of twin-to-twin transfusion syndrome and an anatomy scan. Sarah has mentioned before the importance of not only biometry and assessment of amniotic fluid, but also of Doppler. And there are 3 types of Dopplers. It's the Doppler of the umbilical artery and the middle cerebral artery and the ductus venosus. And those are critical in monochorionic twin pregnancies, but also in dichorionic twins. Dichorionic twins is to assess whether both babies are growing well and their oxygenation is normal. In monochorionic twins, it's a method of assessment of any of the specific complications of monochorionic twins, and I can come back to that. And on each occasion, we need to be reassessing the structure of the babies. In dichorionic twins, we see them at 12 weeks, they look all right. As in singleton pregnancies, the next scan is at 20 weeks and then more or less every 4 weeks thereafter. The issue of delivery, I think that will be addressed in further questions later on, but the recommendation is 37 weeks for dichorionic, 36 for monochorionic, and 32 for monoamniotic, but those can be varied according to the results of your monitoring, I believe. But that is an overall summary of antenatal management. Let us now address different types of pregnancy complications. Preeclampsia. Preeclampsia is important in many countries of the world. It's one of the main causes of death for the mother. More than 45,000 women in the world die every year from preeclampsia, and more than 500,000 fetuses or neonates die as a result of preeclampsia. In twin pregnancies, the chance of premature preeclampsia occurring before 37 weeks, is 9 times higher than in singleton pregnancies. 9 times. So, and the complications of preeclampsia are particularly high if it occurs prematurely before 37 weeks. So in a sense, all twin pregnancies are at substantially increased risk of preeclampsia. In singleton pregnancies, our research has shown that if we assess their risk at 12 weeks by a combination of the ultrasound scan measuring the blood flow in the placenta, the measurement of blood pressure, and the measurement of a hormone called placental growth factor, will be able to identify the vast majority of the most severe types of preeclampsia. And if we give women aspirin, 2 tablets every day, from 12 to 36 weeks, we are substantially reducing the chance of preeclampsia. We haven't got the faintest idea whether the same is true in twins, none at all. The recommendation is that all twins should be receiving aspirin. I think it is wrong if in the absence of evidence, we impulsively do so. And that is why we are now carrying out a major trial involving many thousands of twin pregnancies to find out if aspirin in twins is effective or not. At the moment, there is no evidence that it's as good as it is in singletons, and therefore my attitude is that unless we prove that it is useful, then we shouldn't be doing it. Next point is the dreaded preterm birth, the leading cause of death and handicap in singletons, and of course, the same is true in twins. And here are the statistics. In a singleton pregnancy, birth before, let's say, 34 weeks, because who cares if somebody is born at 36 weeks nowadays? What matters is not to be born before 32, 34 weeks. The risk is about 1 to 2% in singletons, 10 times as much in dichorionic twins, and a lot more in monochorionic twins. 28% in monochorionic twins, 15 in dichorionic, and only 1.7. What can we do to prevent preterm birth? Bed rest. Bed rest, in some studies that were carried out in the past, have shown no improvement in the risk. There was a study in Zimbabwe, when it was called Rhodesia, where they did a trial and they allowed some of them, half of the women, to carry on digging in the fields, and the other half they hospitalized and they put them in bed. The chance of premature birth in those that were hospitalized were higher than in those that were digging in the field. I'm very strongly opposed to bed rest for anything really in medicine. More often than not, it drives people crazy with zero evidence of benefit, certainly not in the case of preterm birth. Cervical cerclage in singleton pregnancies, if the cervix is short, less than 25 millimeters, the normal is about 35, can be beneficial. In twin pregnancies, it has been shown to, if anything, to increase the risk of premature birth. So it doesn't help. And then is this cervical pessary. It's called the Arabic pessary that you put around the cervix. There's controversy there. Some studies have shown this to be beneficial. My studies have found it not to be beneficial. And in a meta-analysis where we put all of the data together, we found it not to be beneficial. Progesterone, I showed 15 years ago that it was very useful in singleton pregnancies if the cervix is short to reduce the rate of preterm birth. In twin pregnancies, there is no evidence that it is useful. The black interrupted line on one and the red diamond is from the various trials that have been carried out, and there's no benefit at all. I have carried out another study that we published last year, where we took a lot of twin pregnancies and we randomized them into having a high dose of progesterone starting from 12 weeks until 34. And on the right, you can see the blue and the red squiggles that are overlapping, that there was no benefit of giving progesterone in the twin pregnancies. If anything, if you look here in the middle on the odds ratios, progesterone somehow, not significant because it was not crossing the vertical black line, if anything, it tended to increase the risk of premature birth. However, in a very small subgroup of women that had a very short cervix, starting from 12 weeks, very small group of a short cervix at 12 weeks, the red is the progesterone and the blue is the control. We substantially reduced the risk of premature birth. So maybe in a very small group of twin pregnancies with a short cervix, progesterone is beneficial. The next thing that I want to discuss is structural defects in twin pregnancies, anatomical defects, anencephaly, heart abnormalities, and so on. Now, we did a major study involving more than 6,000 twin pregnancies, and we found that the incidence of various abnormalities affecting one or both babies was much higher, nearly, well, more than twice as much in monochorionic twins than in dichorionic twins. And this reason for that is what we call the Christmas cracker hypothesis. You start off with a ball of cells that at a certain point, this ball tears itself apart to produce the two babies. Some of the cells that in the early development are beginning to be committed towards the development of the brain or the heart and so on, in this tearing apart process, like a Christmas cracker, you don't get a nice equal distribution, but you get more cells going one way than the other. And therefore, the incidence of midline abnormalities in a monochorionic twin pregnancy is considerably higher than in a singleton pregnancy. So don't be surprised to learn that in identical twins, the chances that one of the two babies having a major abnormality is much higher than in a singleton pregnancy. Which are these major abnormalities? Brain abnormalities, anencephaly, facial abnormalities, facial cleft, heart abnormalities in the middle, and then exomphalos, gastroschisis, and all the way around spina bifida, much higher in one of the two babies of monochorionic twins than dichorionic twins. Let's skip some of these. This is what I had mentioned to you before. If we are going to do an embryo reduction, because one of the babies has an abnormality, the blue histograms show the embryo reduction being carried out at 12 weeks, and the red being carried out after 16 weeks. And you can see that the risk of miscarriage following an embryo reduction at 12 weeks is about 5%, whereas if you do it after 16 weeks, it's 14%. But beyond that, the chance that you will have a very premature birth in the late embryo reductions is much, much higher than if you do the embryo reduction earlier. So if you're going to do an embryo reduction, because you have a fetal abnormality, it's best for this to be done early than late. And that is why it is critically important that the person who is doing the ultrasound scan, especially in a twin pregnancy, is very highly qualified to look very, very carefully to see if we can diagnose as many major fetal abnormalities as possible. I will not address this because I don't think we have time. Let us now address, if I can, some of the complications in monochorionic twins. And Sarah, you can stop me at any time because this may take a bit of time. Essentially, okay, essentially we have 4 types of different pregnancy complications in monochorionic twins. And this slide shows which these are and how common they are. The first one is severe twin-to-twin transfusion syndrome. Twin-to-twin transfusion syndrome is primarily characterized by a difference in the amniotic fluid. The size of the babies, more often than not, in twin transfusion syndrome is similar. What is very different is the amniotic fluid. And then we have selective growth restriction, where the big difference here is in the size of the babies. And this is again because of this tearing apart of the babies in the Christmas cracker type of hypothesis, where more cells go in one baby and one of the fetuses has less cells, less placenta, and it's like having placental insufficiency in one of the babies. In this case, the amniotic fluid in the bigger baby is normal, but the big difference is the difference in the size of the babies. Then we have TRAP, where the 2 umbilical cords are very close to each other, and at a certain point, the one baby is transfusing the other baby as well, and the consequence of that is that one baby becomes anencephalic and acardiac, and it becomes a tumor that is receiving blood from the one fetus who becomes the pump twin that may suffer from heart failure and die. And then what Sarah told us that her twins had, when the size of the babies is similar, the amniotic fluid is similar, but there is a big hemoglobin difference between the two. And the only way to find out is if you're doing Dopplers in the middle cerebral artery. Because if you have a severely anemic baby, the velocity of blood in the brain is much, much higher. And if you have a polycythemic baby with a very high hemoglobin, the velocity is lower. And by looking at these middle cerebral artery velocities, we can see this divergence in the velocity of the two babies, and that's how we diagnose them. How common are they? Well, it's about 10 in 100 severe twin transfusion, 10 in 100 selective fetal growth restriction, 2 in 100 this TRAP sequence, and about 5 in 100 TAPs. So these are all quite common complications. Now, let me quickly go through twin-to-twin transfusion syndrome, where the predominant difference is not in the size of the babies, but in the amniotic fluid. And mainly, this will present itself, if it's severe enough, around 16 to 20 weeks. And it is extremely depressing to me when women come with half-dead babies that had been asking their midwives that their tummy is getting bigger or they're getting pain. They say, don't worry about it, it's because they are twins. It is critically important that these women are having a scan every 1 to 2 weeks, looking at the amniotic fluid. And the features are very simple. Too much fluid in the one side, not enough on the other. And then we assess how bad the condition is by looking at the umbilical artery and the ductus venosus. If the Dopplers are normal, this is stage 1 or 2, and my management is to just see them every week and do nothing much. If the blood flows in either of the two babies, in either the umbilical artery, all the ductus becomes abnormal, then that is stage 3 plus, and those absolutely need to have endoscopic laser surgery, which I introduced again the same year as nuclear translucency 30 years ago, 1992. The survival rate varies according to the stage. If if we are in stage 1 and 2, and sometimes you have to do laser because there is polyhydramnios, too much fluid, the cervix is getting shorter, and we are doing the laser to protect the women from miscarriage. Then the survival of both babies is about 70%, the survival of at least one is 90%. In stages 3 and 4, the survival rate is less, but survival of at least one baby is about 80%. But developmental delay in about 5 to 10% of the cases, and this is mainly not because of the condition, but because of severe premature birth, and because the average gestational age of birth is 32 weeks. So by definition, half of the babies will be born before 32 weeks. Can you do anything about it? Although the evidence is not in favor of interventions to prevent premature birth, I think we should measure the cervical length. And if the cervix is getting very low, you either say, pray to God because you're going to deliver prematurely, or even in the absence of very clear evidence in favor, I would give them a lot of progesterone. And if the cervix continues to get shorter, I would stitch up the cervix. Even if there is no clear evidence of a benefit, you cannot just watch them miscarry and say it's from God. Let us now go to TAPs that Sarah had in her pregnancy. This is a difference in the velocity of blood in the two babies. And the velocity in the anemic baby in the brain is very high in one baby and very low in the other. And then you have this placenta, which is very bulky, this white placenta full of water in the anemic baby, and a black, smaller placenta in the polycythemic baby. You measure the velocities every time you see them, every week. And then if there's a big discordance between them, you stage the type into stage 1 and 2 and 3 and 4 and so on. And for me, if you have an early stage, just observe, because sometimes they reverse. But if you see evidence of progression, then my management is to do laser to separate them. If the pregnancy is very close to 28 to 30 weeks, and it is technically difficult to do laser, then you can gain a bit of time by giving a blood transfusion to the anemic baby and doing an exchange transfusion in the polycythemic baby. What do I mean by that? The hemoglobin is normally like us, about 12. Anemia means that the hemoglobin in one of the babies may be 2 or 3. In those cases, you put a needle inside the umbilical cord or the heart of the baby, depending on the position, and you give blood to correct the anemia. In the baby that is polycythemic, there is a sluggish circulation that can itself produce brain damage because the brain is not perfused properly with well-oxygenated blood. And in these cases, you may put the needle inside the cord again, and then take blood out and put saline in to dilute the blood. Unfortunately, you have to keep doing that every week and sometimes every few days, and you don't really gain a lot of time. So laser, if you can, and if you cannot, and you are approaching 30, 31 weeks, I would deliver the babies. Let us now go to the other condition, and this is selective growth restriction. One baby is growing well, normal amniotic fluid, and the other baby has a smaller placenta because of this Christmas cracker hypothesis and is not growing so well. And we need to decide how badly affected is the small baby, and it is very simple the way in which we work it out. We just look at the umbilical artery Doppler. On the left, the waves run into each other, that is type 1. We just follow them up, And more often than not, nothing is going to change. We get to 32 weeks, and then it's sometimes when the Dopplers go worse, and then we deliver them. The second type is when you have a gap between the waves. This is absent and diastolic flow. In this case, for me, you then assess the ductus. And if the ductus is abnormal, this baby is going to die. And therefore, it is critically important to do laser to separate them. And that sometimes improves the outlook for this baby. But if the baby dies, in any case, the small one, you are protecting the co-twin from death. If in the context of identical twins, one baby dies, then there is a 50% chance of the co-twin dying or becoming severely handicapped. And the type 3 selective IUGR is when the same strip of recording, you see waves that change from very abnormal reverse flow to absent flow and then positive. And this is because the two umbilical cords are very close to each other, and you have blood swinging from the one side to the other. You cannot do a laser in this type, in this case, because the cords are too close together. You just monitor them and hope that you can get to a gestation when you can deliver them. So this is selective growth restriction. And then this is, yeah, let's skip some of this. And this is the trap sequence where one baby, the pump twin, is doing the perfusing of the other baby that has lost its brain and its heart. And it looks like this. It doesn't harm anybody, but sometimes if the anencephalic fetus gets too big, then it puts a lot of strain in the pump twin, which can go into heart failure and die as a consequence of that. In this case, I pass a needle into the pelvis of the anencephalic baby. You can see the blood flow, and then we use laser to interrupt the blood flow in this. And we do that at around 12 weeks. And for you, those of you that have television, it's a very good program about the making of Frida Kahlo, an incredible Mexican painter who illustrates the problems of monochorionic twins in this dramatic painting where you have these connections between the two circulations. I'm sorry that I have overspent my time.
No apologies necessary. Thank you.